Hello, everybody. Hopefully everyone can hear me and see me all right at home today. Thanks for everyone to sign in and listen. We're doing a talk today about prostate imaging in the primary care setting, just to give some updates and some information about what to order and why when we're looking about prostate cancer from a screening point of view all the way through to treatment as well. So we'll get into it for you. Now let's make sure this is working. All right. So just an outline of what we're going to talk about today. We'll look at the imaging options available, the benefits of prostate MRI and the limitations, the use of PSMA PET imaging in prostate, how to refer and what's available from a primary care level, any questions and answers that I can give for people at the end of the talk. All right, so let's talk about who we're looking at here. So in regards to prostate cancer, we really think about men, over the age of 40 up to about 80/85, depending on their life expectancy and comorbidities. It's very rare to see prostate cancer under the age of 40, although it does occur very rarely. We're thinking about people with raised PSA levels as what we usually see as a primary setting. That's the first thing we encounter. We think about men who have got a positive family history of other men in their families, especially first-degree relatives, but also female siblings who may have cancers that suggest a BRCA-positive status. We talk about other biochemical tests that you can have, looking at PSA density and free to total ratios on top of just looking at a PSA number in isolation. And the updated prostate cancer guidelines will be released soon. They're just in the works of being reviewed and updated at this point in time. So hopefully they'll be out in 2025 to help with some guidance. So let's think about a patient. So we've got a man here. His name is Jim. Jim's 60. He's had 2 blood tests within about 3 months of each other, demonstrating a raised PSA level of about 5. You've had a chat to him. He maybe has an uncle with prostate cancer, not a great family history for an increased risk. He's declined to have a DRE performed as part of his workup, and now you've got to decide what to do with Jim. He's got a raised PSA. He's in an age where he's probably thought a bit more at risk, and we need to work out how we're going to work him up beyond this point. Do we do further blood tests? Do we do some imaging tests? Do we send him off to a urologist? Does he have an upfront biopsy? So if we think about the biochemical tests that are available in regards to the PSA levels, we can think about the free to total ratio. If that's decreased less than 25%, then that's considered a significance of the free to total PSA levels in the blood. We can think about his PSA density when that's increased. Most of the nomograms use 15% cutoff, some use a 20% cutoff. So if the PSA density for the size of the gland is too high, then that's considered an increased risk as well. There are a lot of other available tests you can use, such as the prostate health index, etc., but they're used very uncommonly compared to these baseline tests and are not well represented otherwise, and we see them on referrals very uncommonly if we look at that compared to our standard PSA and density and free to total ratios. So in this day and age, most patients with a raised PSA thought of at risk for prostate cancer will go on and have a multiparametric MRI as the gold standard screening test. So multiparametric MRI is as it sounds, 3 parameters is what we use at this current time. We look at T2 imaging in 3 planes. The peripheral zone where most of the prostate cancer is quite bright and cancer is quite dark. So we're looking for a little dark thing in the peripheral zone. We look at diffusion-weighted imaging. So diffusion-weighted imaging is the random motion of water. We presume cancers are tightly packed in regards to their cellular structure, and the water can't move very freely without touching something and changing directions, and we can pick that up on imaging. And we also look at dynamic contrast enhancement. So neoangiogenesis of malignancy is the concept there, where we're looking at early enhancement of the lesion. So this is the current gold standard in men who require screening for increased risk of having prostate cancer. Now, when we report these studies, we'll give you a score. The score is between 1 and 5. It's called the PIRAT score. And the general rule is PIRATs 1 and 2 are considered a benign MRI report. PIRADS 3 is a borderline, and 4 and 5 are positive reports. There are obviously false positives and false negatives in regards to any screening test. So even if you get a PIRADS 1 or 2 report, then some patients will still need an MRI, still need a biopsy, and if they're a clinical high-risk patient. So the general consensus is a negative MRI, PIRADS 1 and 2, has got a negative predictive value for clinically significant cancer of about 90% as a general rule. So this multiparac MRI, we're very lucky in Australia. It is rebatable under the government for referrals from urologists or oncologists. So this is a limited service available in other countries around the world, and we've been very lucky in Australia and been quite a leader in developing MRI as part of the screening program. In regards to a referred study that is not from a specialist, there's an out-of-pocket fee. As a general rule at this point in time, the fee for an MRI from a GP is between $500 and $550 out-of-pocket fee. So that's the thing we've got to think about when we're referring these patients if the rebate is not there. The things that causes a problem with MRI is obviously bowel gas artifact. We do give our patients enemas to try and clear the bowel gas, but it does cause problems with diffusion-weighted imaging in particular. If you've got patients with metallic hip implants, they can cause artifact. Now, the different types of implants cause different levels of artifact, and you really never know until you put the patient in the MRI how bad it's going to be. Some patients suffer from claustrophobia and may need some sedation. Often we get away with a bit of Ativan orally, but sometimes they need IV sedation, which limits them to a lot of our hospital-based practices. And implants and devices is a big problem as well. As our population ages, we're getting more and more patients that have pacemakers and stimulators in situ. And some of these are MRI safe. Most of them these days are MRI safe, but they need to be put into safe mode before you can put patients into the MRI, which makes a problem for us because we have to call out a representative from the technology company to be available, put it in safe mode, monitor the patients when they're in the MRI to make sure they don't have a cardiac event. So this, unfortunately, encounters another fee, and the general fee at the moment for a pacemaker is around $700. So if you have a patient that you're referring in for an MRI, it's got a pacemaker, you could be looking at $1,200 out of pocket for that patient to have his screening test. So it's not a cheap exercise. This is a very busy slide, so we don't need to go through it too much, but just the crux is that if you're over 70, your levels of PSA are 5.5 and above, and a Free to total of less than 25%. Excuse me. If you're under 70, that drops to 3 and less than 25%. And if you're under 70 with a positive family history, then that PSA level drops to 2. So we're just trying to show that as your age comes down and your risks go up, the PSA cutoffs change over time. And from a referral Medicare point of view, that benefit is paid once only in every 12-month period. So now, MR's been around for quite some time now. We are seeing patients who have had 2, 3 or 4 MRs over the last 8 to 10 years. So this is trying to show where we can go away from MRI. So when we look at MRI in your PIRADS grading scheme, most of the numbers suggest that if you have a PIRADS 1 or 2 result, the chance of having clinically significant prostate cancer, that's grade group 2 and above, or the old Gleason 3+4 and above, is only about 2 to 4% or less than 5% realistically. We find the PIRADS 3 lesions, the chance of clinically significant cancer is around the 20%, and obviously going up 50 and 85% for PIRADS 4 and PIRADS 5. Now, if we compare that to PSMA PET imaging, there's a couple of studies that have been published recently, and there's more coming out. The primary study, which a lot of Australian doctors have been involved with, shows that a negative primary score of 1 and 2 has a very low risk of clinically significant prostate cancer. And if you have a positive primary score, then the numbers go up on your positivity for cancer. So this leads us to what's happening a lot more in this day and age in our referral base, is that some patients are low to intermediate risk that had 1 negative test. There's still some risk there that they're considering whether they should biopsy this patient or not. And what we're doing now is doing a PET on top of the MRI to see what we can achieve. And the main one is this first column here. So this is a PIRADS 1 or 2. So these two columns here denoted as MRI negative. And this first column is also PET negative. And so out of all the patients in this, there was no cancer, or there was a very low amount of Gleason grade 1 or 2 cancer. So you're not really getting insignificant cancers. Whereas if you have discrepancy or discordance, things change. So MRI negative, PET positive, the chance of having Gleason grade 3 to 5, this dark red down here, suddenly increases. And then we think about the ones that are MRI positive and PET positive, and then you're getting more and more cancers that are high grade. So the end point of that concept is that some patients who may be adverse to biopsy, maybe have had sepsis in the past, maybe have some comorbidities which are difficult to get around to have to be able to biopsy the patient, like stopping their blood thinning medications, etc. But if you have a negative DRE, low risk on all your blood tests, and 2 negative screening tests, then your chances of clinically significant cancer is quite low, and a lot of these patients can be managed conservatively with appropriate follow-up. So that's kind of how those two tests can work together in the screening population. So this is where we're moving up to now. So Jim does have, say, a cardiac device in, not really keen on spending $1,200 or $1,300 on MRI for screening, but he could also be screened with a PSMA PET. The PSMA PET fee is quite similar to the MRI of around $500 at this stage. There's a lot of PET scanners available, so getting access is not a huge problem. No problems with implants. You don't have to give them the IV contrast if they're allergic or they've got renal impairment. We can just do the nuclear medicine part of it with a gallium. So for people who don't know, this is prostate-specific membrane antigen. It is not 100% specific for MRI. So for prostate cancer, unfortunately, a lot of other processes will be added with PSMA. There's some work ongoing now with renal cell cancer with PSMA as well. There's a maximum of 1 Medicare-funded PET for staging. So for patients who have been biopsied and have got intermediate to high-risk cancer, they're allowed to have 1 MRI for a staging assessment. The accuracy for screening and staging, for screening of patients, is probably pretty close to MRI in general, what is the literature is starting to show, but you lose the anatomical side of your ability to stage for local disease, whether there's signs of extra prostatic extension or sphincter invasion, which may help you end up planning your operation if you're going to go down that pathway. All right, so Jim did have a biopsy and he ended up with low to intermediate risk cancer. So he's got grade group 1 or grade group 2, low volume, minimal Gleason 4 involvement in there. So what do we do with Jim now? He's got low grade, intermediate grade cancer. Do we do an operation? Do we just watch him? What else can we do? So in this day and age, patients can go into active surveillance now. And currently there's no rebate for PET in patients that have been put on active surveillance, but there are rebates for MRI, and you can have 1 MRI in your first year, and then every 3 years after that, unless there are any signs of concern for clinical progression. So that may be a PSA increase, change in the DRE or things like that. Some terminology differences to always think about is active surveillance versus wait-for watching. Active surveillance is you're actually watching this with a plan to intervene. Was wait-for watching, you're just going to provide treatment if the patient can self-report symptomatology in a palliative type setting. So active surveillance is a very common program. Treatment that the urologists are using these days for patients with low-risk cancers, and they can watch these over time. Another option is to go undergo local therapy. So this is a patient that's come through. You can see here, so this is diffusion. This is the ADC map. These go together. It's focally bright and focally dark. This is restricted diffusion in the peripheral zone on the right towards the apex. This is the lesion here on T2. You can see a bit of the normal bright gland. And over here, this patient's actually PSMA negative. So this is a discordant, but biopsy-proven Gleason 3+4 focal small lesion on the right side as part of the templating study. So the rest of the gland's been sampled and there's no signs of malignancy we haven't seen elsewhere. And he has opted for a focal ablation therapy, which has now currently been performed at a few centres in Brisbane. And this is the picture we see on the patient's, sorry, it's slow here, patient's follow-up MRI post-ablation. So you can see the little pathways for the electrodes there on the right, and this is a post-contrast study. So the normal prostate on this side enhances, but the abnormality on the right we've seen in the past is encased by this big defect. So the ablation has encased this area, and this patient we followed up and see whether they have signs of recurrence or treatment effectively, and they've kept their prostate in situ. They don't have the risk associated with impotence and urinary incontinence associated with major operation. So that's an option for patients with lower grade disease and more isolated 1 or 2 lesions depending. Let's just say Jim didn't have low grade disease and he had more intermediate to high grade disease, and he went on for definitive treatment. Now that may be prostatectomy or that may be radiotherapy depending on multiple factors. Now his prostate went away, he was good for a little bit, a year or 2, but his PSA levels have started to creep back up again. So he has biochemical recurrence. So what do we do with biochemical recurrence? So let's say his PSA went to 0 or the lowest nadir on radiotherapy, then PSMA PET is your primary choice in looking for patients with biochemical recurrence. The current guidelines is a max of 2 fundable PSMA PETs in a lifetime for patients who have had recurrence. So in the past, we used to do CT, chest, abdomen, pelvis, and the bone scan as our staging and restaging scans, but this has been replaced by PSMA PET. We sometimes use MRI for this indication if we think there's local recurrence in the pelvis and we want it for radiotherapy planning and staging where to boost to if we need in the pelvis along with that pelvic sidewall and nodal basin. Now you go, well, how good is PSMA in looking at patients with PSA recurrence? And as a general rule, if you come from 0 and you're still less than 0.5 nanograms per mil, then your accuracy is quite low still. You're only picking up 1/3 of cancers available, visible, on the PSMA PET. But as your PSA increases, so does your ability to see it. So PSA greater than 2 is you find 90% of the cancers on the PET imaging. And so you go, well, let's just wait. Why don't we wait until we see it all? The current, the current thoughts on this is that you want to treat earlier if possible. So you want to see what you're treating. Is it local recurrence in the pelvis? Is it distal disease outside? Are we thinking about radiotherapy? Are we thinking about chemotherapy? Are we thinking single agent, dual agent, or triple agent therapy? Most patients have more than just ADT alone these days. And if we look at the papers where patients had bone scan and CT and also had a PET, blinded to the results of both studies, and the PET led to an upstaging or downstaging of the treatment options in around half the patients. You go, well, PET's pretty good then if it changes your management. The only thing we currently don't know is that are these changes correlating with overall survival? It's been around for a while, but not long enough. The data's not there yet. Is this all just lead time bias? We're seeing things earlier, doing things, but not changing the long-term prognosis of these men? We don't know yet. So that needs to be borne out in the data over a longer period of time. All right, here's another option that's available. So Jim, unfortunately, has got severe bony disease, and here you can see this is a PET examination. All these red spots are disease in his bones, a lot of spinal, vertebral, and rib disease. And he had severe osseous disease, a lot of bone pain. He opted for lutetium therapy. So this is theranostics, where we can give lutetium loaded up with the tracer, and its uptake. It's taken up by the cancer cells, and you can treat them locally. And this is a follow-up scan showing a decrease in the volume of bone disease. Now, Jim had a clinical response with decreased pain scores, but this is not a treatment per se in regards to cure. It's a treatment for pain relief. It is not cheap. Most patients will need at least 2 to 3 cycles, if not more, and every cycle is about $10,000 out of pocket. So it's not a cheap cheap therapy at all, but for patients with severe bone pain who is really affecting their quality of life, it is an option for them. All right. So that's kind of where we're going with the modalities available in regards to prostate imaging. And people may ask, what about ultrasound? And ultrasound really doesn't have any role in staging or screening of patients with prostate cancer. It's a great test at looking for patients with urinary tract symptomatology, how they're voiding, is there hydronephrosis, etc. But it doesn't have any roles realistically in looking at prostate cancer. You need to use your MRI, you need to use your PET examination for those two. There's some good information that both can be used in screening, and that may flip across from each other. MRI is the rebatable test for this at this point in time. They're good used in combination for patients who you don't want to biopsy. They're so a great negative predictive value. And PSMA PET is still king in regards to follow-up in biochemical recurrence. Active surveillance is becoming a very common treatment pathway for low-grade disease. We try and get away from too much Gleason 3 + 3 = 6 or grade 1 disease as being malignant. It's nearly a pre-malignant condition with a very, very low risk of metastatic potential, but not zero, unfortunately. So they may still need to be treated. So that's the talk, and I hope people got some information out of this. We did have 1 or 2 questions presented prior, and if I can remember them, one was about the utility of FDG PET. So if a patient has had an FDG PET in the past, and it's positive, you see a focal abnormality, then you need to work them up further. Now you can work them up with a PSMA PET, and they may just need a biopsy of that region of interest based on the PSMA. Most of them, so the FDG, most of them will end up with an MRI to have a look further. And the numbers are probably about 50% of those patients will end up having clinically significant prostate cancer. If an FDG is negative, it's not of value in excluding prostate cancer. So a negative FDG PET for another reason doesn't exclude prostate cancer in a screening setting. We sometimes use FDG in patients who have small cell variant in their prostate cancer, not standard acinar cell type, and some of those are PSMA negative but FDG positive. So we do use it rarely in that situation. This question I've got here is about rechecking the PSA levels. It's more of a urology level check question than for me. Most of them will be checking and are probably 6 monthly in the first year, but the urologist would have a treatment paradigm follow-up for those patients. They would see them back on a yearly basis. If everything's stable, they have their prostate MRI every 3 years, but if the levels go up or there's a change in PSA velocity, then they would probably use that as their indication to recheck with MRI at a sooner level. Some people will re-biopsy early, other people will not re-biopsy depending on what the levels are and the prior biopsy results were. In the past, we really relied on 6 or even 12 core biopsies to sample the gland and thought that was enough, but it probably wasn't. But nearly all patients these days will get transperineal templating performed, and so the whole gland is sampled. So we have a better understanding of the number and the degree of cancer in the prostate before patients enter an active surveillance program. We're not missing the anterior cancers anymore that weren't sampled on a standard old pathway. And for the patients on active surveillance, the urologist will be seeing them on a regular basis. So it's more about where the PSA level was started, how it changes over time. But they will have that treatment pathway laid out, hopefully, for the primary care clinician. Is that MRI only in regards to active surveillance? There's only a rebate for MRI only in the active surveillance. There's no rebate for PSA and PET. It does get used, but that would be an out-of-pocket fee. The PSA, this will come out in the next PSA guideline. So the question is, what is the difference in advice from pathology groups re the upper limits of normal PSA? So PSA is dependent on multiple factors. It's a kind of once again, this is a urologist kind of directed question. It's more an indication of prostate disease, not specifically prostate cancer. If you have a large gland, then your density is obviously going to be less, and so the PSA may be less important in that context compared to a small gland. Obviously fluctuates with inflammatory conditions as well. So the cutoff values, they'll come out in the next updated guidelines, and they'll probably stay pretty similar in regards to what should be considered significant. Like in a screening test, you always have to be more sensitive and specific. So you need to have a lot of people included, more than you need, because you don't want to miss things. Like you need to make sure that your miss rate for clinically significant cancer is quite low. So that's why you set your values at those levels. So the PSA cutoffs will be lower than you could consider, but those kind of 2 to 3.5 to 5.5 levels are pretty constant. Anyone over about 5 is always considered a bit more significant, and then as you jump up over 10, obviously is a lot worse. And the 30s, 40s, and 50s, most of those will end up with metastatic disease, but we've seen many a patient who has PSAs in their 20s and 30s with no signs of cancer or metastases or multiple imaging tests. So it is a test of PSA disease, but it does have quite a big role in prostate cancer. So I don't know if everyone can see this, but we've got Dr. Andrew Hadley from out at Bayside online, which is great. He's indicated that the active surveillance protocols are not well adhered to. Most were previously based on repeat biopsies. Most people will still repeat a biopsy to confirm low-risk disease, and 6-monthly PSA tests and MRIs as required under the active surveillance guidelines. So thank you for that, Andrew. So that's kind of most urologists have their own kind of pathway of how they like to do this, but they will get followed up on a regular basis with those tests. All right. It seems like that's probably the last of the questions that we can see here. Thank you for everybody for tuning in. I hope there was some help there. Always happy if people want to email questions through to me they haven't thought of now that they're interested in hearing about. But yeah, much appreciated for everyone spending their time on this lovely Tuesday night listening about prostate cancer. Thank you very much.